Hi, everyone, and welcome to our first topic of this intensive care unit series. Thank you for coming, and I hope you will learn something from our discussion tonight. By the way, my name is Wilson Salburo, your host for tonight and for next week. And as you can see on your upper left of the screen, this is the playlist or this is the topic that we will discuss for the remaining weeks. And before we begin, don't forget to like and share this video. At the same time, don't forget to subscribe as well. Okay. Uh, this is actually just the first part of the two-part series of patients with mechanical ventilators. This tonight we will be discussing only the overview of this topic because it's quite broad and our time cannot accommodate just in one discussion. Okay, we would proceed now. Patient with mechanical ventilators. Before For us to understand patients with mechanical ventilators, we must first understand the process or the concept of mechanical ventilation. So, what is mechanical ventilation? Mechanical ventilation is a form of treatment that is usually given to a patient in the intensive care unit. However, to advancement in technology, new researches, and new treatment modalities, it's also being used in other areas like in the emergency department, long-term care facilities, and as well sometimes and even in the home care setting. So mechanical ventilation is a form of ventilation therapy that is usually being given to patients who is having respiratory failure, and it can be invasive or non-invasive. To differentiate the two, uh, the only thing that differentiate this is the use of uh, advanced airway. So if there's an advanced airway involved, artificial advanced airway, it means it's invasive. If there's none, it's not invasive. And pressure is involved in mechanical ventilation. It can be positive or uh, negative pressure. However, for this common or these modern times, usually it's positive pressure. So because negative pressure has long been obsolete, and I believe it's not being practiced nowadays. So in relation to this, we discuss like a brief history of negative pressure ventilation. So in the year 1928, and uh, Miss Philip Brinker developed or invented this machine, and this is called the iron lung. So this machine uses negative pressure in helping patients to breathe because during those times, especially in the mid 1900s, there was an outbreak of polio. So when the patient have severe polio, it affects their muscles, also muscles for breathing. So this machine helps them to breathe. So as you can see, this is quite big, and the body of the patient is inside this chamber, and the head would protrude on this part here. So the machine will generate negative pressure so that the air will get inside the lungs of the patient. And as you can see, there are many ports here, and there are windows. These are being used to give medications or do procedures to the patient. But in the around 1980s, this machine was already starting to become obsolete. One is because polio vaccine was already discovered, and advancement in technology and made new forms of next generation of ventilators, which are the ventilators that we know now. So this is an example of a ventilator. Actually, this is quite a new model. And as you can see, compared to the previous one, this is small, lightweight, and quite complex compared to the other one. And the patient is just lying on the bed, not anymore inside the machine, and it's just being connected by this tube or circuit, as we call it, to this machine, and that's it. You don't need to go inside the machine for you to breathe. And also, uh, the one good thing about this machine is it can do both uh, negative and no, sorry, invasive and non-invasive mechanical ventilation. Okay, what are the goals for mechanical ventilation? Actually, the two main goals are facilitate ventilation and facilitate oxygenation. How does it facilitate ventilation? It actually helps in the gas exchange in the alveoli by increasing the rate of breathing and the tidal volume. Average tidal volume for an adult is roughly 500 mils or 7 mils per kg. And how does it facilitate oxygenation? It's by increasing the fraction of inspired oxygen or FiO2, also by maintaining the lung volume, also recruitment maneuvers of the alveoli and PEEP to maintain the baseline alveoli pressure. Okay, as I said earlier, there are two forms of non-invasive mechanical ventilation. One is non-invasive and one is invasive. So for non-invasive, actually there are only two. One is CPAP or continuous positive airway pressure, and the other one is BiPAP or bilevel positive airway pressure. CPAP means in CPAP there's continuous positive pressure that's being applied from the machine to the patient. However, this continuous pressure is being applied throughout the breathing cycle. However, there's no mechanical ventilation that's going on, so the patient should be spontaneously breathing in this mode. On BiPAP, BiPAP, as you can see, bi means two, so there's two pressure that's being set here. The IPAP or the inspiratory positive airway pressure and the EPAP or the expiratory positive airway pressure, which is being set by the doctor or by the respiratory therapist in the ICU, depending on their assessment of the patient. And by the way, for these two modes, the patient should be stable and able to maintain their airway. So this is an example of non-invasive positive airway, non-invasive mechanical ventilation. As you can see, there's no artificial airway that is employed the patient, just this mask connected to the machine via the circuit and attached to the HME filter. So just simple, attach the mask to the patient and make the settings. So the settings would be depending on the assessment of the intensivist and the respiratory therapist. So what are the indications for non-invasive positive pressure ventilation. Can be for severe dyspnea, acute respiratory failure, acute COPD exacerbation, CHF or congestive heart failure, pulmonary edema, and sleep apnea. By the way, sleep apnea, obstructive sleep apnea is actually the main indication for CPAP, while acute respiratory failure and acute COPD exacerbation is the main indication for BiPAP. Okay, now let's proceed to invasive mechanical ventilation. So as I've said earlier, the only thing that sets apart non-invasive with invasive is the use of artificial airway, like endotracheal tube. So in this in modes of ventilation for invasive, we must keep in mind that actually there are only two modes: volume cycled and pressure cycled. However, with different machines, different models, newer machine has more modes that can be set to help the patient breathe. But basically, keep in mind that there's only volume cycled and pressure cycled. And under volume cycled, there are two common modes also, which are volume controlled, which is the most simplest and effective form, and SIMB, or the synchronized intermittent mechanical ventilation. With SIMB, it is being synchronized with the patient's effort to breathe. For pressure cycled, there are two also common modes: the pressure controlled ventilation and the pressure support ventilation. For pressure controlled, the inspiratory pressure and the rate is actually being set, while on the pressure support, it's only the pressure that is being set. The rate is not no minimum rate is being set. And also sometimes, based on the assessment and findings of the intensivists and the respiratory therapies, sometimes they do combine volume cycled and pressure cycled to achieve good results. So what are the indications for invasive mechanical ventilations? Actually, there are numerous indications both for endotracheal intubation and mechanical ventilations. However, we must however, in general, mechanical ventilation should be considered when there clinical and laboratory signs that a patient cannot maintain his or her airway, and if there's an evidence that there is inadequate ventilation and oxygenation to the patient. So one is respiratory rate, which more than 30 breaths per minute. So as we know that the normal respiratory rate for an adult is between 12 to 20 breaths per minute. So having a respiratory rate of more than 30 per minute actually indicates that the patient is already in distress and can be in respiratory failure. Next is oxygen saturation, or arterial oxygen saturation less than 90%, especially if the patient is already in high flow oxygen, or the FiO2 is already in around 0.6 or roughly 10 liters per minute. And next is the pH and the partial pressure of carbon dioxide. For this, we need actually attest the ABG or the arterial blood gas for us to get these numbers. For pH, should if it's less than 7.25, it's an indication for invasive mechanical ventilation, because it's already showing acidosis, because the normal pH is only from 7.35 to 7.45. Also, if the partial or PaCO2 is more than 50 millimeters of mercury, means that the patient already in respiratory acidosis, and the normal PaCO2 is only from 35 to 45. So these four is already are already the are already indications for invasive mechanical ventilators. So what are the complications for mechanical, especially for invasive mechanical ventilators? So as we know that we are introducing pressure to the lungs, positive pressure to the lungs, so sometimes it can cause pneumothorax or air trapped inside the thoracic cavity. How does it do? How does it? How does it do it? How does it happen? So when pressure is being introduced, sometimes air or air is leaks into the pleural space via the alveoli and being trapped there. So it can cause that causes uh, pneumothorax. Oxygen toxicity. Sometimes when the patient actually is constantly on high flow of oxygen, especially if the FiO2 is around zero point 0.6 for prolonged period of time, it can cause fibrosis to the patient. Hypotension. Hypotension actually is side effects or because of the effects of opioids and sedatives that's being used to put the patient in in that's being given to the patient in the ICU. And it can also be because of pneumothorax. So if there's too much pressure in the thoracic cavity, the heart cannot pump enough blood in the other parts of the body, which causes hypotension. And also it can cause lung injury because of the extreme pressure. Sometimes it can cause destruction of the alveoli because of incorrect settings or of the machine. I think that's all for my report, for my discussion tonight. And these are the reference. Okay, let me end my topic with a passage from the Bible. Then the Lord God formed the man of dust from the ground and breathed into his nostrils the breath of life, and the man became a living person. Genesis chapter 2, verse 7. Okay, thank you for attending this podcast. I hope you learned something. And if you have any questions, you can always drop me an email at wavler@hotmail.com. I hope to see you next week for the second part of this presentation. Again, have a nice day and keep safe, everyone. And don't forget to like and share this video if you haven't already. Thank you very much and see you again next week. Bye.